Thank you for the nice introduction. So today I'm happy to be going into the invitation of the organizers, which I'm happy to assist here with the talk. And today it's going to be about chronic kidney disease of unknown etiology, and I'm going to tell about a bit the journey we made throughout this with this disease to see and try to understand it, and also try to improve diagnosis and see what potential mechanisms might be driving this disease. So actually, the story begins already before I even started research in the early 90s, where in Sri Lanka and Nicaragua, El Salvador, Nicaragua, so Central America, physicians noticed there was an increase in chronic kidney disease in their wards, and they did not understand how it came, so they tried to describe what these patients were like, and actually there was not much to tell. Actually, there were male patients, sometimes females and children as well, but mainly they were young, active in the farming field. They have increased creatinine, that's hence their CKD. They have no proteinuria or some trace proteinuria. They have smaller kidneys on ultrasound, but there are no real risk factors explaining or that might explain their CKD or even towards the cause. So no hypertension, no congenital disease, no diabetes, no glomerulonephritis or any type of disease. So this was kind of an enigma. Why do these patients have CKD? Hence the term CKD of unknown etiology. The decay in kidney function is fairly swift. When you go normally from your 45 years of age, you will lose about 1 milliliter per minute per year. For these patients, it was fairly fast. So even from beginning on, early age on, they lose about 3 to 5, sometimes 6, 7 milliliters per minute per year, so it's a fast progressing CKD, and numbers on this are coming in now and since the last 5 years. On the histological level, nothing much specific either there. It's termed a chronic interstitial nephritis, where you can see tubular atrophy, interstitial fibrosis, also some inflammation, cellular infiltration is there, striate fibrosis. So all these aspects are indicative of a chronic interstitial nephritis. Hence, in some regions, also in Sri Lanka, this disease was also termed chronic interstitial nephritis in agricultural communities, given these epidemiological and clinical context. Now, what is the downside? It's always diagnosis by exclusion. So this makes it really hard to also investigate and find mechanisms behind this disease. Now, this was a situation like 30, 40 years ago. This is what it is today. So with already some effort, and we and others, of course, in trying to map out where this disease actually occurs. And it ranges from really proven cases up to word of mouth, because sometimes in these low and middle income countries, it's not easy to assess or catch the right proper data to really confirm disease there. Now, as you already know, and I also do the introduction, there was a big still a big fuss about it. Okay, what's the cause? So it gets a lot of attention. And we got the opportunity a couple of years ago to investigate a biopsy study. And actually, this helped us to get insight in the two major hypotheses by which this disease was thought to develop. The first one was heat stress dehydration, because these people are working, farmers are working in low middle income countries, mostly in tropical and subtropical areas, not having enough rest in the shade, not drinking enough water during the daytime, so that the kidney goes through a repeated process of dehydration, heat stress, and this continued during the day and during a harvest season, for example, could then cause chronic kidney disease. The other hypothesis was, okay, maybe it's due to environmental or agricultural toxins, because these patients and these male farmers, also their families, are living actually in a contaminated environment. Still up today, etiology, mechanism, diagnosis, and prevention continue to be challenging. So there are some arguments which actually do not support a heat stress hypothesis. This is quite still a matter of debate, but there are some arguments not supporting that. For example, this is in the northern area of Sri Lanka. And you see here the distribution of the disease. In green, you see where the paddy farms are, so the rice fields. Blue is absence of disease, and red is actually red zones, herds of this disease. So certain hotspots in this area where disease is present. And if we would assume that heat stress or dehydration or environmental temperature would play a role, we would expect a more equal distribution of these hotspots across this area. However, it's located onto several areas, which turn out to be certain use of well water. Another argument came from Cuba, or actually Central America, where we know in El Salvador and Nicaragua, they have the same altitude and also the same crops are being harvested and maintained over there. In Cuba, it's the same story there. However, the main difference is that in El Salvador, Nicaragua, the disease CKDU or SINAC is occurring, and in Cuba, it's not present. And this has been nicely documented since Che Guevara was there, and he was a medical doctor, and he implemented medical registry, so it was quite tightly regulated. And there was no instances. The biggest difference between these two areas is that in Cuba, there was no allowance of pesticides due to the ban from the US. This was again also a circumstantial argument. Another argument came from literature. What about environmental or agricultural toxins? So a couple of years ago, Valk et al. Did a nice meta-analysis trying to see, okay, let's analyze all epidemiological studies which have now been performed on CKDU and the environment and see what comes out of that. And they actually scored several papers which have higher explanatory value. And the strongest papers or the strongest studies each point towards the use of or the exposure to pesticides, either via the drinking water or being it licensed pesticide applicators. So each time there was a nice correlation, at least a strong suggestion. Then another argument came from the Green Revolution. As you know, since more than a couple of thousand years, there's been traditional farming. No real reports of CKDU, at least that we can dissect. And since the 1980s, 60s, 70s, the increase in mechanization and agrochemical use has been a fact. And it's quite striking that SINAC or CKDU is appearing since the early 80s, early 90s in this period and is still continuing up to today. Now, these are all, of course, anecdotal and some circumstantial evidences. Now, we got the opportunity to investigate biopsies from these patients coming from different countries in an unbiased way. We were actually not pathologists. We just had the tissues. Okay, let's now look at these tissues in an unbiased way. Maybe we can learn something about this disease. So what we got the opportunity was to investigate tissue from El Salvador, France, also in Europe, India, and Sri Lanka. We did the biopsy. We got the biopsy tissue. We observed, of course, what is already known about the specific lesions pointing towards chronic interstitial nephritis. And one thing really struck our attention. It was in the Jones-Silver staining. So now this staining is not staining for silver. It's making use of silver to perform a histochemical staining. And this staining actually is applied to in histopathology to demonstrate the basement membrane of tubules, as I here delineate. What we noticed in these tissues was an accumulation of these dark granules inside the cells, inside the epithelial cells, which was quite striking and unexpected to us. And there were also unaffected tubules, as you can see here. So it was clear that it was a biological effect taking place. Now, these granules could reach up fairly high sizes. As you can see here in panel B, even the size or even surpassing the size of a nucleus. This is all variations of the same staining because we played around with the actual technical conditions for the staining to really visualize these granules. And we see here, for example, in panel E, that the lysosomes, well, these granules at that time, we didn't know it at that time, are really big, have heterogeneous content. So they are dysmorphic, and we see this accumulation in these epithelial cells. They were also autofluorescent, as you can see here. We see this also as some kind of marker to reveal their presence. This was shown on unstained tissue section. And we also demonstrate that this indeed was we were looking at the same thing, because we first did an autofluorescent imaging of the autofluorescence, and afterwards did the Jones staining on the same section. And as you can see, each dot which was autofluorescent is also appearing on the Jones staining. So this was actually from methodological point of view, a step forward, because now we could use both the Jones staining as well as autofluorescence to assess these strange granules at that time. So of course, when you have to tackle with a rather unknown disease, you have to build up the story. And first question is, okay, in which tubular segment of these kidneys do actually these argyrophilic or autofluorescent granules appear? This is actually a patient from Sri Lanka, where you're looking at the first part of the glomerulus and the connection to the proximal tubule. And even there, in this blowout here on the right, you can already see that these dark granules are present already early in the proximal tubule. We further confirmed this by staining. If you look here to the left at panel A and D, these are actually serial sections. You can see here PT is proximal tubule, where the epithelial cells are demonstrating these black argyrophilic granules. Two distal cells are not showing them. And the origin of the segment was confirmed here with GGT1 staining, which is actually a proximal tubular marker. Proximal tubules show the lesion. Distal tubules, which are absent from this marker, do not show the lesion. This was also confirmed by two other stainings, intestinal alkaline phosphatase and leucine aminopeptidase, two other proximal tubular markers. Now, okay, which other histological features are there also in the kidney associated with these structures? We have conserved epithelial height, so sometimes fairly normal, but also atrophic tubuli in the context of fibrosis, basement membrane thickening, also interstitial expansion. So all the features were there, and this was something to be added. Now, what are these argyrophilic autofluorescent granules in proximal tubular cells? It was the next question, and we had a couple of, quite a series of stainings to really dive into what are these. And I will already tell you here that were lysosomes, actually the stomachs of the cell, sort of say. And how did we actually prove that? We did it by using markers for lysosomal enzymes. So cathepsin B is actually an enzyme inside of the lysosome. And here we can see we first did an immunofluorescent staining for cathepsin B, showing where lysosomes are in the tissue. And after that, on the same section, we performed the Jones staining, which is actually a chemical staining. So it just overrules the immunofluorescent staining. And there you can see that one by one, the fluorescent cathepsin B matches that of the Jones staining. This was actually a first proof of that we were dealing with lysosomes. We also further confirmed it by confocal microscopy, also for cathepsin B, so an intralysosomal protease, as well as for LEMP1, which is actually a membrane marker of lysosomes. So this is here showing that with the cathepsin B, internal lysosomal enzyme is nicely matching the green autofluorescence, thereby turning out yellow. And the same for the LEMP1, which nicely stains the membrane of the lysosomes, which are also autofluorescent. Now the next question was, okay, let's dive deeper into this. How do this look under electron microscope? Because we want to understand what it looks like. And then what we see here is the following. Here you see three proximal tubular epithelial cells next to each other. Here below is the basement membrane. On top is the brush border. And in one of these cells, there's an accumulation of these dark dysmorphic structures, also granules, which are even more pronouncedly filled with these aggregates, with these round dispersed aggregates. And the structures itself are fairly dysmorphic. These structures can be fairly huge. So this is easily reaching up to 7 microns. This is easily the size of a nucleus or even bigger. That can be seen. And also sometimes we see smaller structures of these dispersed in these cells, but below the 1.2 micrometers, which we think is kind of a set of to being normal versus pathological. What are these structures? We then checked, okay, we did like a bit of a Google reverse image search. We found, okay, autophagosomes doesn't look like that we are dealing with that in our CENIC or CKDU cases, because they have a fairly double membrane and various content, which is not the case for these granules we have. Then myeloid bodies have also a completely different structure and a lipid onion layering, which we do not see in our cases. And also lipofuscin, we did not observe to be quite dispersed how it is looked at in literature, but these are some examples thereof. And also there, this was not what we see for our droplets. So this was not all this case. So what was then in search for what it is, what we're looking at, because we have to be sure that what we see in electron microscopy is the same as what we see in light microscopy. We therefore did here a blowout of what we can do on light microscopy. So this is why this is quite a bit blurry, because we're really pushing the edge of the microscope here. And then what we found on the electron microscope was the following. So this is not even the same patient, not even the same, not the same tissue, not even the same patient. What you see that there's already a match in structure of cellular structure, and even in electron microscopy, we see some of these granules which really resemble what we see on the light microscopy. So this was quite a suspicion, the suspicion that we would again deal with lysosomes, but not an actual proof to our understanding. That's why we went one step further. And as I showed you in the beginning, we were able to demonstrate these granules on the Jones staining, basement membrane, as well as these dark stained granules. And then we also worked together with Cynthia Nast from UCLA. And we actually challenged her by asking, okay, first we will do a staining for Jones staining, and the staining contains silver and gold metals. This is really important to understand. What we see here is actually silver and gold deposition as part of this staining. We provide the staining, and you try to make an electron microscopic grid out of this tissue. If we then put this grid under the electron microscope, we can also perform something which is called EDM-TEX, so transmission X-ray diffraction. And we send over an electron beam, and this allows us to, at specific spots in the tissue, to do chemical element analysis. So element-specific fluorescence can be picked up. So this would allow us, if we point the beam at certain spots, to identify which chemicals or elements are there. So actually we are looking for silver and gold. If we see silver and gold in these black dots, we know that they are lysosomes, since we have proven it on light microscopy. This is how it looks in real life. So the other example was quite to illustrate. So what we see here centrally, left and right, this is a big nucleus of two cells, two panes here. And here on the right hand side, you see the basement membrane. And when we checked for with the EDX, we saw that in the basement membrane as a positive control, we saw silver and gold being present. As control regions, we have a random region inside the cell and even outside the cell. We measured no silver and gold, but for the dark granules, which we showed in the electron microscopy to be there, each contains silver and gold, confirming that the staining actually takes place in that direction and that we are dealing with lysosomes on that matter. So it was quite a workaround, and immunostaining on EM would have been much easier, but as it turned out, this was quite challenging at the time as well. So then we went on and asked, okay, now we have maybe something specific, maybe not. Let's see how frequent this phenotype is. That's why we did a larger biopsy study. So we included our 35 cases of SYNAC CKDU, and we compared them to up to 100 non-SYNAC nephropathies. This included drug exposure and toxic nephropathies, calcineurin inhibitor treatment, interstitial nephritis, other proteomic nephropathies, whatever we could find. And also we included 45 healthy control kidneys, either from uninvolved parenchymy from tumor nephrectomies or also even implantation biopsies. What we saw there was that regardless of the location on the earth where we could retrieve the cases from, each time we found that in these cases we found these granules, these lysosomes, dysmorphic structures to be present in the proximal tubular epithelial cells. So this was actually an argument that we were dealing with the same disease at that point. We found ourselves a prevalence of 81% throughout our cases, and then last year there was another study of Daniel from Erlangen, who then showed that 62% in a kind of repetitive study. So actually this was quite reassuring. What was quite striking to us was the fact that we also observed the same lesion. At first we thought it was quite specific for the disease, turned out not to be the case, but by being as specific, there was something very striking about. And we observed the exact same lesion in patients taking calcineurin inhibitors. So this is an example of transplant patients having got a transplant kidney who are being treated with immune suppressive drugs of the type calcineurin inhibitors, both with cyclosporin A and with tacrolimus. we could observe the same lesions in these kidneys, which was quite interesting because calcineurin inhibitor immune suppression is actually nephrotoxic. Although it saves your transplant kidney and you keep your kidney for 10, 12, up to 15 years or even sometimes longer, they are inherently nephrotoxic and eventually lead to the demise of your kidney. So this actually was a strong argument to see that, okay, now we have something which is to do with nephrotoxicity, and we see also in these patients the same lesions with the unknown disease. So maybe there is something toxin involved in their etiology, actually providing evidence towards the more environmental/agricultural toxin hypothesis rather than heat stress. We also found other diseases where drugs are involved, light chain disease, clomiphene, lomustine, and also lithium. These cases, some of these cases, we also found these lesions to be present, and some publications really point towards nephrotoxicity. Then one other argument, we said, okay, now let's try and look in the transplant cases. We could, with the collaboration with Slovenia, we had access to protocol biopsies, meaning that we have biopsy from the same patients at implantation, 6 months later, 12 months later, and at indication. This is actually a separate cohort. And in these patients, we look at the electron microscopy, both electron microscopy and light microscopy, and we scored for, okay, the lesion is absent. We are suspicious, so we see these smaller granules, or it's really confirmed when we see these big dysmorphic lysosomal structures. And then what we see was the following. In our implantation condition, we had a fairly low presence of this lesion, whereas in the protocol biopsies that show that 6 months and 12 months, it increases with increasing exposure to calcineurin inhibitors. This was a nice correlation or association we found. It's not real proof, but it's just occurring in association with. And even the highest incidence was found in patients who needed a biopsy because the kidney function was decreasing again. So that's why they called here the indication biopsies. Now, also on the mitochondrial level, we saw some abnormalities, both on the electron microscopic level. So swelling, dysregulation of the cristae was also present. And we then also did staining on patient tissue for this. So this is again to remind you that the autofluorescence is the lysosomes that we see in the tissue. Here is a double staining where we have autofluorescence, so no actual staining for the lysosomes, and in red is a mitochondrial marker. Actually, you would expect for the COX-6C marker that in every tubule this marker is expressed, since every cell has mitochondria. But for some reason, the tubules which present these abnormal lysosomes, this marker at least is not present, and it's part of the electron transport chain. Here you can see some instances. Luckily, biology is not black and white story. So here we have some instances where there is overlap between the two. So probably we might be looking at some kind of process really going on in the tissue. Of course, we wanted to verify this. What does the two hypotheses? Do we see the same also what we see in patients as it also occur in rodents? That's why we performed a rat study where we did a dehydration of rats and we compared it to toxin-induced etiology for Cynac. And as a toxin, we used actually cyclosporin A, because of all of the pesticides circulating, we could not choose in a sensible way which one to take. That's why we said, okay, let's take cyclosporin as a correlation, as a relevant alternative given the findings in humans. So what we did was then, okay, we did cyclosporin exposure for 4 weeks, 50 milligram per kilogram or 40 milligram per kilogram, and also dehydration, meaning that the rats were deprived of water for 10 hours. And during these 10 hours, they were put 30 minutes per hour in a hot environment of 37 degrees. And then you can see here by urinary osmolality that indeed the dehydration group had higher urinary osmolality compared to cyclosporin and control groups. Now what we see in the tissue, of course, we were looking at the lysosomal lesion. In controls, this is a situation in rats here, and dehydrated is like this. And then in cyclosporin, we see presence of these darker, bigger lysosomes appearing. There were also areas in the cyclosporin treated rats where there is atrophy, so this atrophic patches where the tubules really are getting injured in these tubules. So we think this is like the primary onset of really injury in these kidneys, somehow associated to the lysosomes not being in their normal behavior. When we look up here, we had a closer zoom up of our rat study. We have, okay, here this atrophy of the tubules, expansion of the interstitium, and this is electron microscopy. So we see here these big bags, darker stained in the electron microscopy, which probably resemble these lysosomes. I need to remind you that what we see in humans is not exactly what is mimicking here in rats. This is something we're now looking into because for all we know, maybe rats can never do what humans do. So this is something with the translation we need to look into. But it shows anyway that by giving the cyclosporin in rats, the endolysosomal compartment is affected. We also did a Jones staining in combination with the LEMP1 to show that we're really dealing with lysosomes also in rats, and this turned out to be the case. And then also we did some proteomic study here on the right, and this actually showed, also in the rat study, and this showed that in the calcineurin inhibitors and dehydration conditions, both were injurious to the kidney, both were showing injurious pathways, but they were of different nature, with the calcineurin inhibitor pathway more showing towards toxic pathways, whereas dehydration had more to do with general physiological adaptations. And then also in this context, it is worth to mention that the last year a study was published on the urinary protein of the CKDU patients, and there also was profiles discovered on mitochondrial, lysosomal, and protein reabsorption processes, actually somehow confirming or at least putting more evidence on the table towards the mechanism we think might be happening in these kidneys, or at least based on their exposures. So in conclusion, what we learned from this trip was, okay, the etiology, we can say it's a global disease. There's support for environmental toxins. We have also diagnosis, which we think added something to this. But the fact that when we do at light microscopy, we see the black granules, okay, we can say it's suggestive for this lesion. We also know that in cases of heavy proteinuria, this feature appears. Hence, it's necessary to also do electron microscopy, where you can really verify that there is the presence of these dark, bigger, dysmorphic lysosomes containing these dispersed, this mottled pattern. And in terms of the mechanism, we're quite in the dark. We know maybe some big players, but it's just all a matter of further research that mitochondria and lysosomes most likely are involved to some extent. This is, of course, many questions to be asked, how it really progresses the cell. Is it really, to what extent is it affecting the cell function? We see it also appearing in rather healthy looking cells. Remember the electron microscopic image where there is still some brush border present. And what is the impact of environmental toxins of agrochemicals on it is also a matter of further investigation. Then to sum up or to summarize, or to end actually this presentation, I would like to point out to a study published just this year from Sri Lanka, where they actually investigated the role of drinking water in the occurrence of this disease. It was already from the beginning on thought by some groups that, okay, the drinking water might be contaminated. There have been many studies. None have been really conclusive on that part. But here was the idea, okay, let's look at historical numbers between 2010 and 2020. And something which they did there was taking data from three sources. One, they collected the incidence of hospital-diagnosed CKD and CKDU. So they didn't make a real distinction between CKD and CKDU, because it's fairly hard to make with the data which was present. Also, they implemented CKD and CKDU screening program. So they had an idea, okay, where in the country, in the northern province of Sri Lanka, is CKD occurring or really prevalent? And then they compared it to where the provision of drinking water via reverse osmosis plants was installed. So reverse osmosis actually purifies the water and provides clean water, clean drinking water to this to the local villages. And this is actually what they found. So the incidence of CKD, CKDU in the time course 2010, 2016, 2019 is actually decreasing a bit. First, it's increasing from 2010 to 2016. It's getting worse. Two areas here in the north are worse. Here you see more red and pink, which is actually bad news. But since then, by 2019, it has decreased again. If this is compared to the availability of reverse osmosis water, it was being installed in 2016, and by 2018, the whole region already had more than 40% of the villages covered with reverse osmosis water. Now, this is quite colorful scheme. Now, this is how it looks like when you do actually put the data together in the graph. They did it in two areas in the northern central province, Anuradhapura and Polonnaruwa. And what you see here is in the blue line is actually the incidence, annual incidence of CKD, CKDU, and it's going up from 2010 up to 2016. Then it goes down again. The same in the other area, up to 2016 it increased, and it goes down again. And here the green dots are actually the percentage of families who are having access to reverse osmosis water. So here you see that since 2015 it's quietly, nicely increasing, and this falls together with the decrease of CKD and CKDU. And then the conclusion actually was that as soon as 20% of the families having access, around 20-25% of the families having access to reverse osmosis water in a community, then the incidence of CKD, CKDU starts to decrease. And this is actually another scheme of the 20 plus regions they investigated in this area, each time showing there's a decrease in the incidence of CKD or CKDU in these cases. So with this being said, I would like to thank you for attention, and I will be happy to take any questions.